Hello everyone, I am Kayuri, a third year physiotherapy student, and my topic is fracture neck of femur. I will explain its clinical features and radiological findings. So, first of all, introduction, types of femoral neck fractures. So, femoral neck fractures are classified as intracapsular. It means that within the hip joint capsule, or extracapsular. It means that outside of the capsule. By convention, fracture of the neck of femur refers to the extracapsular type, also known as intertrochanteric fracture. So, the key difference will be intracapsular neck fractures almost never unites due to disrupted blood supply, while intertrochanteric fractures nearly always unite. So, intertrochanteric fractures also present with more severe signs and symptoms. Fracture neck of femur almost never unites due to disruption of blood supply to the femoral head. In contrast, fractures nearly always unites. So here the picture of it. This is the greater trochanter, this is the capsule, and this is the femoral head. So between that, intracapsular fracture could occur. Then there's a lesser trochanter, and then there's trochanteric fracture of the trochanteric site. Then there's a subtrochanteric fracture could occur. Then what will be the clinical presentation of it? So an elderly patient with groin pain and inability to bear weight will be there. Then often injury will be there. It means that sleep or missed step could be. Then minimal initial pain, swelling may lead to delayed diagnosis. Then impacted fractures could be mild symptoms, but persistent groin pain will be there. So patient typically present following a trivial fall, as we said, missed steps, or they could sleep. Then subtle onset of symptoms, especially in impacted fractures, often results in delayed presentation and diagnosis. So careful clinical assessment is essential. Then what will be its clinical examination finding? So first, the leg will be externally rotated, means patella facing outward. Then there will be slight shortening of affected leg. Then there will be tenderness in groin and painful hip movements will be there. Then inability to perform active straight leg raising will be there. So on examination, the affected limb lies in external rotation with visible shortening. So groin tenderness and painful hip movements with muscle spasm are hallmark signs. Active straight leg raising is characteristically impossible due to pain and loss of hip stability. Then its radiological findings. X-ray imaging is the cornerstone of diagnosing fracture neck of femur. So a standard X-ray of pelvis including both hips is essential for accurate assessment, comparing and detection of both obvious and subtle radiological signs. So first are X-ray pelvis including both hips for comparison. It will help detect fracture and subtle signs. These are the essential for diagnosis confirmation. So this is the X-ray of the hip showing fracture neck of femur fixed with 3 cancellous screws. As we can see, there is a fracture. So the sign number 1, medial cortex break. On epi view X-ray of the pelvis, a break in the medial cortex of femoral neck is the primary and most direct radiological sign of fracture neck of femur. The medial cortical line normally appears as a smooth continuous arc. Any disruption, angulation, or step off in this line indicates a fracture. Always compare with the contralateral hip for the subtle cases. Then there is sign number 2, prominent lesser trochanter. It means due to external rotation of the limb, the lesser trochanter becomes more prominently visible on the epi X-ray. So it means anatomically the lesser trochanter is situated on the posteromedial aspect of the femoral shaft. In the neutral position, it is partially hidden. When the limb externally rotates, as occurs in the fracture neck of femur, the lesser trochanter rotates into profile and appears usually prominent. Comparing both hips, the same X-ray is essential to identify the subtle but important sign, as we said earlier. Sign number 3, overriding of greater trochanter. In the fracture neck of femur, the greater trochanter is displaced upward due to the overriding of fracture fragments. Normally, tip of the greater trochanter lies at the below the level of the femoral head, as we can see here also. With overriding, it rises above the level. So, the key radiological indicator of the significant displacement and the shortening of the affected limb we can see and consider. So, it will indicate significant fracture displacement. Then sign number 4, trabecular stream and Shenton's line. So first, trabeculi are bony struts within the femoral neck, arranged in the predictable arching patterns. A fracture disrupts this trabecular pattern, visible as a break of discontinuity in the trabecular stream on the X-ray. So we can basically see the stream on the X-ray, and if it's disrupted in impacted fracture, no clear fracture line is only bending or buckling of the trabeculi. So it means that it could be the sign, but at the end we should compare it with the opposite. Then disruption of Shenton's line. It means that the line is smooth, continuous arc drawn along the inferior border of the superior pubic ramus and the medial border of the femoral neck. Normally, it forms an unbroken curve on epipelvis X-ray. So, if there will be any fracture, displacement or dislocation of femoral neck disrupts, this arc will be disrupted, and we will able to see that on X-ray. A broken Shenton's line is a reliable indirect sign of the femoral neck fracture of the hip joint pathology. So these two pathology we can consider also. Then impacted fractures. Its special consideration, no clear fracture line will be there. In impacted femoral neck fractures, there is no obvious fracture line visible on X-ray. Instead, only a subtle bending or buckling of the trabecular pattern is seen. The trabeculi appear compressed or angulated at the fracture site. This makes impacted fractures particularly easy to miss on initial radiological assessment, leading to delayed diagnosis and potential displacement if the patient continues to bear the weight. And then comparing it with opposite hip. It means that comparison with the contralateral opposite hip X-ray is essential, as we discussed earlier also. It will discuss the subtle asymmetry in trabecular alignment, cortical contour or femoral neck angulation. It can be only appreciated when the both sides are viewed together. Any persistent groin pain following a fall, even with near normal X-ray, it warrants MRI or CT for confirmation. So at the end, if it's still doubtful, we can go for MRI or CT for the confirmation at the end. And early detection prevents displacement and avascular necrosis. Now let's see one clinical case of it. An 82-year-old woman presents to the ER after a minor sleep on the wet floor. She complains of growing pain and inability to bear weight on the right leg. On examination, the right leg appears shortened with the patella facing outwards. Active straight leg raise is not possible. So, as we can identify the feature and signs, external rotation and shortening of the leg is there, break in the medial cortex sentence line is there, we can see the x-ray and the prominent lesser trochanter on the x-ray we can see also. Thank you, and this is the reference.